Imagine a silent, insidious threat, lurking undetected in millions of lives. A risk so profound, it tragically claims more lives annually than many forms of cancer combined. Yet for years, our most powerful defenses against it have been deployed based on information that, while groundbreaking at the time, might no longer fully capture the complex reality of how we treat disease today. What if the very tools designed to snatch people back from the brink were being applied using an outdated map? How do we, as patients, families, and clinicians, make truly life altering decisions when the ground beneath our feet is constantly shifting, redefined by new science? Today, we're going to plunge into just such a fascinating medical puzzle, one that impacts countless lives, exploring how cutting edge research is challenging long held assumptions and, crucially, paving the way for truly personalized medicine. It's really a story of science constantly evolving, always striving for better answers. Welcome to the deep dive. Our mission, as always, is to distill the most important nuggets of knowledge from, well, a stack of sources, giving you a shortcut to being truly well informed. Our focus for this deep dive is a crucial reassessment of implantable cardioverter-defibrillator, or ICD therapy. Specifically, we're looking at its role in the primary prevention of sudden cardiac death in patients living with heart failure and reduced ejection fraction, a condition often referred to as HFrEF.
That's HFrEF, yeah.
Right. We're drawing our insights from recent cutting-edge research, including a comprehensive state-of-the-art review, to offer you the clearest, most concise understanding of this complex and, frankly, incredibly vital medical landscape. We're here to highlight those aha moments, give you the surprising facts, and, well, hopefully offer just enough humor to keep you absolutely hooked. The central tension we'll be exploring today is this. Current guideline recommendations for ICDs are largely based on landmark studies that actually predate major advancements in how heart failure is medically treated.
Exactly, that's the core issue.
This shift in medical therapy changes everything about how we understand risk and benefit, and we're here to unpack why that matters for you.
And before we really unpack this crucial topic, we absolutely want to extend a very special thank you to London Heartbeat Said Academy UK. Their educational support truly makes deep dives like this possible. It's their commitment to advancing knowledge that allows us to bring these really in-depth discussions to you. So we wholeheartedly encourage all of you, our curious listeners, to explore their extensive range of over 150 popular courses. These courses are designed for, well, a wide array of learners, whether you're a healthcare professional looking to deepen your expertise, maybe a student, or simply someone eager to understand complex medical topics. And please, don't miss out on free, regular updates. Subscribe to their social media channels on Facebook, Instagram, and YouTube. It's a fantastic way to stay informed, keep up with new developments, and ensures you won't miss any of our future amazing discussions.
Okay, so let's start with the silent killer itself. Sudden cardiac death, or SCD. It's the primary focus here, and its impact is truly pervasive, often striking without warning. What exactly is SCD, and just how immense is the problem we're talking about globally?
Well, SCD is, and I don't think this is an exaggeration, a monumental public health issue. When we look at global mortality statistics, it's actually a leading cause of death, not just in the United States, but worldwide. It remarkably surpasses cancer mortality rates.
Wow, surpasses cancer. That's huge.
It really is. That alone gives you a sense of its scale and, the urgency behind understanding it better. Now, when we talk about the immediate mechanism behind SCD, the most common malignant rhythms that directly lead to it are ventricular tachycardia, or VT, and ventricular fibrillation, or VF. These are essentially chaotic electrical activities originating in the heart's lower chambers, the ventricles that effectively prevent the heart from pumping blood.
So the electricity is going haywire, but the pump isn't working.
Exactly. Think of it like a car engine sputtering wildly but not actually turning the wheels. The heart's electrical system is firing, but there's no coordinated mechanical action to circulate blood to the body and brain. It happens fast. Now, the highest incidence of SCD is observed in patients who have a prior history of cardiac arrest, so those who have already experienced a life-threatening heart event. But more broadly, it's highly prevalent in individuals with structural heart disease. And most specifically for our discussion today, we see a significantly elevated risk in those with a reduced left ventricular ejection fraction, or LVEF.
LVEF, that's the pumping strength measure, right?
Precisely. It's a critical measure, expresses a percentage, that tells us how effectively your heart's main pumping chamber, the left ventricle, pushes out blood with each beat. A reduced LVEF means the heart isn't pumping blood as strongly as it should. And it's really important to remember that the foundational clinical trials, the ones that specifically prove the efficacy of ICD therapy, were focused squarely on patients with HFrEF. That's heart failure with reduced ejection fraction.
Oh.
And this was regardless of whether their heart failure was caused by ischemic cardiomyopathy, meaning due to blocked arteries and damage from a heart attack, or non-ischemic cardiomyopathy, often referred to as NICM, which includes a whole range of other causes like genetic conditions, infections, or maybe long-standing high blood pressure.
So ischemic from heart attacks, non-ischemic from other stuff. Got it.
Right. And this distinction between ischemic and non-ischemic is important because while ICDs showed benefit in both, the journey for these patients, their underlying disease, and, well, the subsequent treatment nuances can differ considerably.
That definitely sets the historical stage for current recommendations, but as you said, it comes with that crucial caveat. The context has profoundly changed. So let's turn our attention to those foundational studies, the landmark ICD trials for primary prevention. These trials were designed with a very specific, really ambitious goal to reduce all-cause mortality, not just death from arrhythmias. Why was that distinction so critically important, especially considering, the significant financial costs of an ICD and the fact that these patients have other competing risks for mortality?
That's a fantastic question, and it really gets to the heart of clinical trial design and, frankly, healthcare economics.
Yeah.
From a public health standpoint, and certainly from an economic perspective, demonstrating a reduction in all-cause mortality carries far more weight and impact than merely reducing one specific cause of death, like an arrhythmia.
Makes sense. You want the overall win.
Exactly. The ICD is a substantial investment. The device itself, the surgery, potential complications later on.
Yeah.
If a patient is successfully saved from an arrhythmic death by their ICD, but then, succumbs to progressive heart failure or another severe illness shortly thereafter, the overall survival benefit for that individual and for the population becomes limited. So these trials aimed for that broader, more compelling outcome, really validating the device's comprehensive impact on the patient's life expectancy. Let's delve into the early pioneers, specifically those post-myocardial infarction studies. The MADIT-I and MADIT-2 trials were truly seminal, game changers, really.
Right, I've heard of those.
Yeah, they fundamentally reshaped how we thought about primary prevention for sudden cardiac death. MADIT-CERD back in '96 focused on patients who'd had a heart attack and had a significantly weakened heart, an LVEF of 35% or less, plus some electrical abnormalities. It showed that patients who got an ICD had significantly better survival compared to those just getting medical therapy. Building on that, MADIT-2 in 2002 found similar improved survival with an ICD in post-MI patients, but this time with an even lower LVEF threshold, 30% or less, and slightly less strict criteria for the electrical issues. These were powerful findings that really cemented the role of ICDs for this high-risk group and pushed them into mainstream practice. However, a significant debate then emerged around whether an ICD provided a survival benefit for patients immediately recovering from an acute MI, like right after the heart attack.
Ah, the really vulnerable period.
Exactly. The concern was that in that very early unstable phase post-MI, other risks might actually outweigh the benefit of preventing an arrhythmia. So two main trials tried to answer this, DYNAMIT and IRIS. DYNAMIT, published in 2004, looked at patients with LVEF 35% and impaired autonomic function, enrolled pretty soon after their MI between 6 to 40 days. IRIS in 2005 enrolled patients with LVEF 40% and non-sustained VT, also evaluated early, 5 to 31 days post-MI.
Okay, so what did they find in that early window?
Well, what both of these trials found was really fascinating. While there was no statistically significant reduction in overall mortality, there were fewer deaths specifically blamed on arrhythmia in the ICD groups compared to the non-ICD groups.
Huh. So it stopped the arrhythmias, but people still died at the same rate overall.
Pretty much. It highlighted that, yes, ICDs could effectively prevent sudden arrhythmic death, but they didn't necessarily improve overall survival in this very early post-MI period. Likely because there were other big competing risks for mortality during such a vulnerable recovery phase, things like another heart attack or worsening heart failure, which the ICD doesn't directly fix.
That's a huge distinction. So those early trials really shaped the understanding for post-MI patients, basically setting a new standard of care, but maybe not immediately after the event. That's a massive shift right there. But then the puzzle got bigger, didn't it? How did the research expand beyond just ischemic heart disease, the heart attack damage, to consider other causes of heart failure, specifically that non-ischemic cardiomyopathy, the NICM?
Exactly. That was the next major frontier. Did ICDs offer the same protection for patients whose heart failure wasn't caused by blocked arteries? And that's where SCD-HFT, the sudden cardiac death and heart failure trial, became the pivotal study for NICM primary prevention.
SCD-HFT, right.
Published in 2005, SCD-HFT was remarkably comprehensive. It enrolled a broad group of patients, roughly an even split, about 52% ischemic, 48% non-ischemic. These patients also had moderate to severe heart failure symptoms, NYHA class 2 or 3, and that reduced LVEF of 35% or less. The key finding: a significant 23% lower mortality rate in patients randomized to get an ICD compared to those getting placebo or amiodarone, which is another antiarrhythmic drug.
And did it work for both types of heart failure, ischemic and non-ischemic?
Yes, crucially, the benefit, the efficacy of the ICD was similar across both the ischemic and the NICM subgroups. This was a monumental step. It confirmed the ICD's life-saving benefit beyond just post-MI patients, really broadening it out to HFrEF in general. Following ICD-HIF, we had the definite trial out in 2004, which focused specifically on NICM patients. These folks had an LVEF under 36% and some ventricular ectopi, basically extra or abnormal heartbeats.
Okay, so a more targeted group within NICM.
Right. This trial showed a statistically significant reduction in the risk of sudden cardiac death with an ICD, which is good. However, when it came to overall mortality, the reduction, while you could see a difference 14.1% in the control group versus 7.2% in the ICD group, it didn't actually achieve statistical significance.
Ah, so close, but not quite statistically.
Exactly. It suggested a strong trend towards overall benefit, but didn't cross that critical statistical line. It kind of underscored that while the ICD clearly prevented arrhythmias, the overall mortality picture in NICM could be more complex, maybe influenced by other factors we hadn't fully grasped yet.
It sounds like while there's this consistent, strong signal for preventing the sudden cardiac death part with an ICD, the overall mortality benefit can be a bit more nuanced, like you said. That leads us directly to the Danish trial, which has been, well, quite a point of discussion and even some controversy in the cardiology world, hasn't it? What did Danish contribute and what made its interpretation so tricky for doctors?
You're absolutely right. The Danish trial definitely stirred the pot. Published in 2016, it was designed specifically to re-examine the ICD benefit in non-ischemic patients. What it found was, well, no statistically significant reduction in overall mortality when comparing the ICD group to the control group. The numbers were 23.4% death rate in the control group versus 21.6% in the ICD group over about 5 years.
That must have been a surprise.
It was, for many, seemingly contradicting earlier findings. However, and this is a crucial detail, sudden cardiac death was significantly lower in the ICD group, 4.3% versus 8.2% in the control group.
Okay, so again, it stopped the SCD, but didn't change the overall death rate significantly.
Concisely. The device was clearly doing its job preventing sudden arrhythmic death, but in this specific study, that didn't translate into an overall survival advantage. Now, the complexity in interpreting Danish largely stems from a really significant contextual factor: the widespread use of cardiac resynchronization therapy, or CRT, within the trial.
CRT, that's the special pacemaker, right?
Exactly. A remarkable 58% of patients in Danish were eligible for and received CRT. CRT synchronizes the heart's contractions, improves pumping efficiency, and importantly, it independently reduces mortality in heart failure patients with certain electrical patterns on their ECG. So this makes it incredibly challenging to isolate the specific benefit of the ICD versus optimal medical therapy only, because CRT itself is such a powerful therapy influencing outcomes. You're essentially comparing ICD plus excellent medical therapy plus CRT versus just excellent medical therapy plus CRT in many cases.
Ah, so it muddies the waters comparing ICD versus just meds.
It really does.
Yeah.
Interestingly, a secondary analysis of Danish did show that the ICD was associated with a significant all-cause mortality reduction in patients who were 70 years old or younger.
So maybe age plays a role.
It suggests age is an important modifying factor, yeah. Adding another layer of nuance. To try and clarify some of this conflicting data on NICM, a meta-analysis pulling together 4 randomized NICM trials was done. This combined analysis ultimately did demonstrate a 25% reduction in all-cause mortality with an ICD attempting to provide a clearer signal despite the variations in individual trials like Danish.
That's a great point about the medical therapy context and how CRT fits in. It really underscores why we can't just apply findings from 20 years ago without looking at how treatment itself has evolved. Feels like we're always running to catch up with the science.
You've hit on a critical insight there. It's a fundamental lens through which we have to view all these landmark ICD trials. There was significant heterogeneity, basically, a lot of variation in the background medical therapy patients received across these studies. Why? Largely because the optimal heart failure medications we rely on today simply weren't standard or maybe even available back then.
Right, like the beta blockers and ACE inhibitors weren't universally used yet.
Exactly. For instance, in the original Madid trial, beta blockers and ACE inhibitors, both cornerstone heart failure drugs, now were prescribed to only a minority of patients at discharge. Beta blockers were given to just 8% in the conventional therapy arm versus 26% in the ICD arm. ACEIs were about 55% versus 60%.
Wow, that's low compared to today.
It really is. So this means the remarkable survival benefits seen in MADIT, while foundational, might not fully generalize to how heart failure is managed today, where optimal use of these meds isn't just standard, it's mandated by guidelines. The very baseline of care is shifted dramatically. And furthermore, cardiac resynchronization therapy, CRT, hasn't just evolved, it's emerged as a truly independent therapy, proven to reduce mortality in patients with a wide QRS interval that's specific electrical abnormality as powerfully shown in trials like CARE-HF. We've seen strikingly low rates of arrhythmic death in more contemporary trials where CRT is common. For example, in MADIT CRT, the arrhythmic death rate was only 1.2%. And in Danish, whereas we just discussed 58% of patients got CRT, the arrhythmic mortality was a mere 1.8%.
So CRT itself is preventing a lot of these deaths.
It strongly suggests CRT has a significant independent impact working alongside the medications. It's interesting, actually, to compare CARE-HF, which studied CRT without an ICD, and it showed similar mortality rates to SCD-HFT, where patients got a single ICD lead only. It really underscores the profound importance of electrical resynchronization from CRT alongside optimal medical therapy. It's not just about stopping a chaotic electrical storm. It's about improving the heart's overall pumping function, making it less prone to those storms in the first place. This evolving landscape of medical and device therapies creates a much, much more nuanced picture than those initial trials could possibly capture.
Okay, that makes perfect sense. The clinical trial environment is so meticulously controlled, almost like a lab setting, right? Designed to isolate specific things. But of course, the real world often plays by different rules. So how do those tightly controlled clinical trial results compare to the everyday reality for patients and doctors? How does the very definition of sudden cardiac death translate? And what does the real world data tell us about its causes and how common it is when these ICD recommendations hit actual clinical practice?
That is indeed a crucial distinction, and where a lot of the challenge lies. In clinical trials, SCD is usually defined very precisely. A death that occurs suddenly, within a short time, often minutes to an hour, in the setting of a presumed or confirmed lethal ventricular arrhythmia. But in routine clinical settings, without continuous monitoring or immediate access to objective evidence like interrogating a device or doing an autopsy, judging SCD based solely on clinical observation is quite prone to errors, biases, misclassifications, because a much fuzzier picture outside that controlled trial setting.
So what looks like SCD might not always be SCD.
Potentially, yes. For example, what might appear to be SCD in the community could actually be a sudden, profound drop in blood pressure from a non-arrhythmic cause, or maybe a massive stroke, or even an acute pump failure event. It's harder to be certain. To really unpack the causes of SCD in the, let's say, messy real world, we can look at powerful studies like a San Francisco autopsy study from 2011 to 2014. This study prospectively looked into unexplained out-of-hospital cardiac arrests, aiming to find the true underlying cause. It found the autopsy-derived incidence of SCD was about 17 per 100,000 person years, confirming it's a significant issue. The leading causes they identified. Coronary artery disease was number one, accounting for a substantial 32% of cases.
Okay, blocked arteries.
Right. Then, maybe surprisingly, drug overdose was next at 13.5%, which really highlights an emerging public health crisis. Then came non-ischemic cardiomyopathy at 10%, and hypertrophy or abnormal thickening of the heart muscle at 8%. Delving a bit deeper into how these contribute. Coronary artery disease can lead to SCD directly through acute ischemia, a sudden lack of blood flow triggering dangerous rhythms like polymorphic VT or VF. Or it can be due to reentrant arrhythmias caused by fibrosis, the scarring from a previous heart attack. For non-ischemic cardiomyopathy, hypertrophy and fibrosis are commonly seen in autopsy cases of SCD. These structural changes are often intimately linked to other significant prevalent conditions like chronic kidney disease, long-standing high blood pressure, diabetes, certain valve diseases, and obesity.
So lots of interconnected problems.
Very much so. We're also seeing a bit of a shift in how SCD presents in the real world, with an increasing proportion presenting as pulseless electrical activity, or PEA, rather than just the classic VF.
VEA, what's that again?
PEA means the heart's electrical system is still firing. There's electrical activity on the monitor, but it's not actually pumping blood effectively. It's a distinct and often more challenging scenario to manage than VF. And it's important to remember that death from progressive pump failure, which is different from sudden arrhythmic death, is more likely associated with advanced overt symptoms of HFrEF, often seen in end-stage heart failure. So we're dealing with multiple ways people can die from heart failure, and an ICD really only addresses one specific pathway, the sudden arrhythmic one.
That paints a really stark picture of the challenges in the real-world diagnosis can be tricky. Other factors are at play. So despite all the incredible medical advancements we've touched upon and the clear promise of ICDs, there seems to be this persistent, concerning gap between what happens in controlled trials and what we actually see in everyday clinical practice. Can you elaborate on this reality gap and why it's such a significant issue?
Absolutely, and it's arguably one of the most critical challenges in heart failure management today. It's a concerning observation that real-world SCD rates and the overall proportion of deaths in HFrEF patients have not declined as rapidly over the past decade as we had genuinely hoped, despite the availability of these powerful therapies. This persistent high mortality is strongly linked to what we call poor implementation of guideline-directed medical therapy, or GDMT.
Meaning the drugs aren't being used optimally.
Exactly. Too often, patients are not receiving the optimal medications, and they're not getting them at the optimal target doses that were proven to save lives in the trials. This suboptimal implementation is, unfortunately, directly associated with the continued rise in heart failure-related mortality out in the community. Ultimately, when we look at the bigger picture, there's a troubling lack of compelling evidence that the risk of SCD has significantly declined in general clinical practice, especially outside of highly specialized heart failure clinics, often academic centers, where adherence to guidelines tends to be much higher. The fundamental differences between patients enrolled in those tightly controlled trials and those we see in real-world practice are quite stark. Trials, by design, tend to enroll healthier patients, fewer severe comorbidities, closely monitored, often able to tolerate the optimal higher doses of GDMT.
Right, the ideal patient in a way.
In a way, yes. In stark contrast, real-world patients often present with a much higher burden of morbidity, more coexisting chronic diseases like kidney disease, diabetes, lung disease. They frequently have more severe heart failure symptoms, and often, due to their complex health profiles, they simply cannot tolerate the optimal target doses of GDMT, or they experience side effects that limit their ability to stay on these critical meds. These factors, the patient profile, the level of monitoring, the ability to optimize medical therapy, likely account for the continued high risk of death and SCD in these patients outside of trial settings. The numbers are quite sobering, actually. The absolute rates of all-cause mortality, cardiovascular death, and SCD remain 2 to 5 times higher in population, community registry, and real-world studies compared to those carefully selected and managed trial patients.
2 to 5 times higher. Wow.
Yeah. Even though overall cardiovascular survival rates have improved significantly since the 1970s, reductions specifically in SCD haven't been consistently observed across the board in the general population. This widening implementation gap between what we know works and what actually gets applied, the persisting residual risk, despite new therapies, and the increasing burden of comorbidities like obesity, diabetes, hypertension, CKD, and atrial fibrillation. These are all significant contributing factors to these persistent and, frankly, vexing challenges in truly moving the needle on SCD rates.
That really helps us understand the gravity of the situation. So what does this complex, evolving picture of heart failure treatment and real-world outcomes mean for the current ICD recommendations? Given all these nuances, the changing medical therapy landscape, how do current guidelines try to balance the, profound benefits of an ICD against its risks and the patient's overall health picture?
That's the million-dollar question for clinicians, right? Current U.S. guidelines on heart failure therapies still very strongly recommend ICDs for patients considered at increased risk of SCD, and they provide pretty clear criteria for who qualifies. The strongest recommendation, a class I meaning strong evidence, general agreement it's beneficial, applies to patients with either non-ischemic or ischemic cardiomyopathy, an LVEF of 35% or less, and NYHA functional class 2-3 symptoms, so mild to moderate limitations.
And they need to be on the right meds too, right?
Absolutely crucial. These patients must also be on optimal guideline-directed medical therapy and have a reasonable life expectancy, generally considered more than 1 year. It's also a Class I recommendation to offer an ICD at least 40 days after a heart attack for asymptomatic patients who have a very low LVEF, 30% or less. This waiting period allows the heart some time to potentially recover post-MI before making that permanent device decision. Beyond these broad categories, there are vital special considerations and a real need for significant individualization for specific patient groups. This includes patients with certain familial cardiomyopathies that have known arrhythmogenic features, hypertrophic cardiomyopathy where the heart muscle is abnormally thick, cardiac sarcoidosis, which is an inflammatory disease hitting the heart, and various channelopathies, genetic conditions affecting the heart's electrical system.
So less common causes need a closer look.
Exactly. For these unique groups, careful, thorough consideration of risks versus benefits, usually involving a multidisciplinary team, cardiologists, electrophysiologists, maybe geneticists is highly recommended. The decision-making becomes much more individualized, based on the specific genetic mutation, disease progression, and the patient's whole clinical picture. Now, on the flip side, there are very clear situations where ICDs are not recommended. The potential harms or lack of benefit outweigh any theoretical advantage. The guidelines give a Class 3 recommendation, meaning evidence suggests it's not useful, maybe even harmful for patients with very advanced heart failure and a limited life expectancy.
Okay, who falls into that category?
This specifically includes patients with NYHA functional class IV heart failure symptoms, even at REN, who aren't candidates for advanced therapies like transplant or VADs. It also applies to patients with multiple severe comorbid conditions or significant frailty that would realistically limit their ability to experience any improved survival from an ICD beyond about a year. The reasoning is both pragmatic and compassionate. These patients are far more likely to die from other causes, like progressive pump failure or complications from their other illnesses, rather than a sudden arrhythmia. Plus, they might experience unnecessary complications from the ICD itself without really gaining significant survival time, which could detract from their quality of life. It's important to note an interesting point, though. ICD therapy is still recommended in selected NYHA functional class. Patients those who are asymptomatic but have significant risk factors, like ischemic cardiomyopathy and a very low LVEF of 50%. And here's a crucial, maybe unsettling fact. The majority of patients who ultimately die from SCD are, ironically, asymptomatic at the time of the event.
Wow, really? Most have no symptoms right before.
That's what the data suggests. They don't necessarily have severe, overt heart failure symptoms leading up to it. This underscores the immense challenge of identifying those truly at highest risk, even without obvious symptoms, and highlights that a significant residual risk persists even when patients are on optimal GDMT.
Here's where it gets really interesting and often quite complex. We've been focusing a lot on LVEF as the primary measure, but what you're hinting at, and what seems clearer in the research, is that it's only one piece of a much larger, more intricate puzzle, isn't it? It sounds like we need to zoom out and consider the whole patient picture, what you called competing risks. How does this holistic view fundamentally change how we think about assessing someone for an ICD?
It changes everything. It really does. And it's truly the direction personalized medicine needs to head. Because ICDs primarily work by stopping life-threatening arrhythmias, it is absolutely essential to differentiate the overall percentage risk of sudden cardiac death from all the other non-SCD causes of death when we assess the overall mortality benefit from an ICD for any given patient. Therefore, it's vital, truly imperative, to transcend beyond LVEF as just a single isolated risk number when evaluating patients. Think of LVEF as maybe a broad screening tool, but definitely not the final word.
So what else goes into that equation?
Other crucial risk markers that have to be considered include the patient's age and overall functional status, specific genetic factors or infiltrative diseases like sarcoidosis, or other complex arrhythmogenic causes driving their heart disease. Also, their overall burden of arrhythmias. How many abnormal beats are they having? And critically, the reversibility of their heart function and structural changes. Can the heart muscle actually improve? We call that reverse remodeling. Furthermore, common comorbidities like frailty, chronic kidney disease, diabetes, and atrial fibrillation can significantly influence the patient's overall prognosis and thus impact how effective an ICD might be, sometimes diminishing its benefit or increasing its risks. Age, for instance, is a very significant factor requiring careful discussion. In older patients, the survival benefit from an ICD might be considerably less pronounced. Why? Well, it's a combination of factors. Their naturally reduced life expectancy compared to younger folks, a higher number of often complex comorbidities that can cause death independently of an arrhythmia, and an amplified risk for complications from the device itself, simply because older bodies can be more fragile. To put this in perspective, studies show up to 10% of ICD recipients over 65 have conditions like frailty or dementia. In this specific group, the risk of death is actually double within the first year after getting the ICD compared with patients who don't have those conditions.
Double the risk of death. That's sobering.
It is. It doesn't mean age is an absolute no, but it definitely demands a more nuanced conversation about realistic expectations and potential downsides. Then we have specific comorbidities, each with its own challenges. patients with end-stage renal disease, ESRD, on dialysis. The evidence for ICD benefit is less clear, often less compelling. These patients are significantly more prone to ICD-related complications, infection, lead issues. A substantial number of deaths in this group are not related to ventricular arrhythmias. In fact, as many as 22.5% of ICD recipients on dialysis die within 1 year of getting the device from non-arrhythmic, causes things like electrolyte problems, fluid overload, other metabolic issues. Because of this, current guidelines generally do not recommend ICD implantation for patients on dialysis. The risks often outweigh the potential benefits.
Okay, so dialysis is a big red flag for ICDs. What about diabetes?
Diabetes is another important one. Patients with diabetes have about a 2.6-fold increased risk of sudden cardiac death compared to those without. So it's clearly a risk factor. However, the data on ICDs in diabetic patients is a bit conflicting. Some observational studies show reduced survival benefits in ICD recipients with diabetes, maybe due to more non-cardiac problems or microvascular disease. Yet, sub-analyses of other big trials noted similar survival benefits between diabetic and non-diabetic patients, especially after a heart attack or with heart failure.
So it's not a clear yes or no for diabetics either.
Not a blanket statement, no. Personalized assessment is absolutely key. And finally, atrial fibrillation, AFib. When it occurs alongside heart failure, it significantly increases the risk of inappropriate ICD shocks.
Inappropriate meaning the shock wasn't needed.
Exactly. The device mistakenly identifies a rhythm like rapid AFib as a dangerous ventricular one and delivers a painful, unnecessary shock. These aren't just physically painful. They can lead to severe psychological distress, post-traumatic stress disorder, anxiety, depression, all of which are themselves linked to poor outcomes and reduced quality of life. So, yeah, incorporating all this detailed info on competing risks and their potential impact on ICD outcomes is absolutely crucial for a truly patient-centered, shared decision-making process.
That truly is a lot to consider. It makes me wonder, with all these competing risks and individual nuances you've laid out, are clinicians often in a position where the best decision isn't totally clear-cut, where they have to balance potential benefits against these very real non-cardiac risks? How do you navigate that gray area? This leads us right to the crucial role of shared decision-making, or SDM. How does SDM bring the patient into this complex discussion, letting them truly partner in these really intricate choices?
That's precisely the gray area we often find ourselves in, and it's exactly why shared decision-making isn't just, a nice to have. It's an absolutely integral part of patient-centered care. It's strongly recommended by all the leading professional medical societies. It's fundamentally about empowering the patient to be an active participant in their own care. Clinicians need to go beyond just relaying the facts. They need to acknowledge and deeply understand each patient's unique values, their personal goals for their care, their preferences, and then counsel them accordingly. It's not about dictating a decision. It's about fostering an open, honest, and really comprehensive conversation. This open dialogue means discussions must highlight not only the potential survival benefits an ICD might offer, but also critically thoroughly cover the potential complications associated with the device and the significant impact of those other comorbid conditions on the overall effectiveness and the patient's experience with the ICD.
So, talking about infection risk or the inappropriate shocks with AFib.
Exactly. Explaining those helps paint the complete picture. Through this thorough process of shared decision-making, patients can make truly informed decisions because they gain a comprehensive understanding of all their options, the potential benefits, and the potential consequences of each path. And it's also vital to remember that patients' values can, and often do, evolve over time, especially as their disease state changes or as new life circumstances arise. This means these crucial discussions might need to be revisited and reevaluated periodically. That could be about the initial ICD decision, or even sometimes the profound decision of deactivating existing ICD therapies if their goals shift towards comfort over aggressive intervention later on. It's truly a dynamic, ongoing partnership.
That's a powerful point about values evolving and needing to revisit care plans. Now, you touched on it earlier, but let's dive deeper into a really concerning aspect of the clinical trial history and, consequently, its real-world application inequities. What disparities have been observed in ICD use, particularly regarding representation in those pivotal trials that form the bedrock of our current guidelines?
This is an incredibly critical area, one that demands significant attention and active efforts to fix. Historically, and quite problematically, the major landmark ICD trials have consistently and disproportionately underrepresented both women and non-white individuals.
How underrepresented are we talking?
Well, to be specific, women represented less than 10% of patients enrolled in earlier foundational trials like MADIT and MESPICE. Even in more recent large trials like MADIT-2, Definite, SCD Heft, and Danish, they still made up less than 30% of participants.
Less than 30%, even recently.
Yes. This persistent underrepresentation means our evidence base for ICD efficacy is predominantly derived from studies in men. Similarly, Black patients accounted for less than 20% of all patients enrolled across these major randomized ICD trials, despite having a higher prevalence of heart failure and SCD in some populations. And the most recent Danish trial, notably, did not randomize any Black patients.
None at all. Wow.
Zero. This profound lack of diverse representation has significant implications for how generalizable the findings are to the broader patient population clinicians actually treat. We're essentially applying data from a narrow slice of the population to a much wider, more varied group. Now, when we specifically look at racial disparities in outcomes, data from a combined database of patients from the MADIT and RAID trials, both large ICD studies, revealed some concerning trends. Black patients with non-ischemic cardiomyopathy showed increased rates of both ventricular and atrial arrhythmias. Consequently, this led to increased appropriate and inappropriate ICD therapies. And unfortunately, most critically, they also experienced lower survival rates compared to white patients in those same trials.
So more arrhythmias, more shocks, and lower survival for Black patients in those trials.
That's what the combined data suggested. And this aligns with previous clinical data consistently indicating that Black patients with NICM generally face a higher risk of heart failure hospitalizations and death overall. The implication of this, as some researchers highlight, is profound. The lack of Black patient representation in trials like Danish could have actually influenced that study's primary outcome, potentially obscuring a benefit for this specific subgroup. So despite such trial limitations, it remains ethically and clinically important to continue offering primary prevention ICDs to eligible Black patients, while also actively recognizing the potential for different outcomes and the urgent need for more inclusive, representative research moving forward. Furthermore, we see clear sex disparities in ICD utilization. While ICDs are generally underutilized across the board, this underutilization is even more pronounced among eligible women and Black individuals.
Why the sex disparity? Any ideas?
It's complex and still being studied, but possible explanations include physician bias, perhaps an unconscious bias rooted in the fact that the evidence base, as we discussed, came predominantly from male populations in those early trials. Adding to this, a meta-analysis combining several major ICD trials actually revealed a lack of all-cause mortality benefits specifically in women for primary prevention ICD therapy.
No benefit for women in the combined data.
Not a statistically significant one, no. This was attributed at least partly to the disproportionately low enrollment of women, which unfortunately compromised the statistical power to definitively detect a survival benefit in that group. But this perceived lack of benefit in the meta-analysis could, in turn, subtly or explicitly sway providers from referring eligible women for ICDs, creating a kind of reinforcing cycle of disparity. Beyond provider perception, there are also significant structural barriers. For racial disparities, for example, Black patients are statistically more likely to seek care at facilities that might lack the specialized resources or robust infrastructure needed for effective device implementation and long-term management. Additionally, Medicare patients from racial and ethnic minority groups often face significant challenges: financial burdens like coinsurance, practical issues like transportation to specialized centers, facility accessibility, varying levels of health literacy. These all create substantial structural barriers to accessing and adopting ICDs compared to others who might have more privileged access.
So it's systemic issues too.
Absolutely. To truly address these deep-seated inequities, future research must not only enroll diverse populations, but also actively focus on understanding sex-specific factors, socioeconomic factors like neighborhood deprivation, and crucial cultural considerations. Only then can we inform targeted interventions to truly bridge these gaps and ensure equitable access to life-saving therapies for everyone.
That's a crucial and often overlooked part of the conversation, really highlighting systemic issues within healthcare. But amidst these challenges, there's also incredible, truly game-changing progress happening on the medical therapy side. Let's shift our focus to the revolutionary advancements in medical treatments for heart failure, which directly and profoundly impact this entire ICD conversation. Contemporary guideline-directed medical therapies, or GDMTs.
Indeed. The advancements in GDMT are nothing short of a new era of hope for patients living with heart failure. The most recent 2022 guidelines from the ACC, AHA, and HFSA now give a Class I recommendation, the strongest endorsement to 4 distinct classes of agents. What's remarkable is that these agents collectively target 5 distinct physiological pathways involved in heart failure progression, all rigorously designed and proven to reduce both morbidity symptoms, hospitalizations, and mortality death in patients with HFrEF.
These are the famous four pillars.
Exactly. The four pillars of modern medical therapy for heart failure. Evidence-based beta blockers, BBs. RAS inhibition, which includes ACE inhibitors, ARBs, or the more recent and powerful RNI. Mineralocorticoid receptor antagonists, MRAs. And the newest class, sodium glucose cotransporter 2 inhibitors, SGLT2I. This quadruple therapy represents a seismic shift. It's important to understand the historical impact, though. Even the earlier GDMTs, ACE-IRB, BB, and MRA already achieved significant reductions in cardiovascular mortality and specifically sudden cardiac death. They laid the groundwork. For example, a landmark 1987 ACEI trial in patients with severe heart failure, NYHA class 4, showed a substantial reduction in total mortality. Interestingly, this was primarily driven by reducing progressive heart failure deaths, not initially SCD, but later studies showed ACEIs did reduce arrhythmia-related mortality and milder heart failure, NYHA 2 and 3. Then in 1996, the U.S. carvedilol study showed that this specific beta blocker produced a 2.1% absolute risk reduction in SCD, direct impact. The Copernicus study later replicated this in sicker patients. And finally, a landmark 1999 trial of spironolactone, an MRA, demonstrated a remarkable 29% relative risk reduction in SCD, even before beta blockers were widely used. So these earlier therapies already built a strong foundation. But the real game changers, the true breakthroughs reshaping the landscape, have been the arrival of ARNI and SGLT2I. Since their landmark studies, ARNI in 2014 and SGLT2I in 2019, treatment and prognosis for HFrEF patients have profoundly improved.
Okay, tell us about RNI first.
Right. In the pivotal Paradigm HF trial, RNI was found to reduce the risk of sudden cardiac death independently of ICD use. It even showed benefits in patients who already had ICDs or were eligible for them.
So it has its own anti-arrhythmia effect.
It seems so. And an analysis of the PROVE-HF study looked specifically at ICD-eligible patients on RNI therapy. After just 6 months, their LVEF actually improved to above 35% in a remarkable 32% of patients. By 12 months, that number climbed to an astonishing 62%.
Wow. 62% improved enough to potentially not need an ICD based on LVEF.
Potentially, yes. That's a significant finding. ARNI therapy, by improving heart function, might take patients out of the LVEF range that currently qualifies them. What's more, PROVE-HF also showed that higher RNI doses actually led to fewer ICD therapies being delivered and fewer episodes of V2VF. The data are similarly promising for SGLT2I. A meta-analysis showed SCD risk reduction in diabetes patients. And in the DAPE-HF trial, focusing on HF patients with LVEF 40%, dapagliflozin, and SGLT2I, significantly reduced SCD and ventricular arrhythmias, and this benefit was seen independently of whether the patient had diabetes or not.
So broad benefits there too.
Powerful, broad-spectrum benefits, suggesting SGLT2I's protective effect goes beyond just metabolic control. This contemporary four-drug regimen, RNI, BB, MRA, SGLT2I, when used optimally, overwhelmingly reduces mortality and morbidity. The impact on life expectancy is truly remarkable. Studies project survival could increase by 6.3 additional years for a 55-year-old and 4.4 extra years for a 65-year-old on optimal quadruple GDMT.
That's incredible, years of extra life.
Transformative therapies. However, and this is a critical, frustrating problem, most patients are not receiving optimal doses.
Still the implementation gap.
Exactly. The CHAMP-HF registry back in 2018 showed only a shocking 1% of eligible patients were getting target doses of the initial 3 pillars. More recently, a VA assessment showed suboptimal prescription rates across the board. BB's 79%, but ARNI only 12%, MRA 30%, SGLT2s just 11%.
Only 11% on SGLT2s. Wow.
It's really low. The implication is huge. If GDMT could be rapidly initiated and titrated up, maybe ICD implantation could be delayed until LVEF is reassessed. With significant LVEF improvement, many might no longer meet ICD criteria. Fewer unnecessary implants, fewer complications. But the unfortunate conclusion is, because quadruple GDMT is currently used in less than 1 in 5 eligible patients, substantial improvement in implementation is absolutely needed to realize these potential benefits. The science is there, but the execution needs massive systemic improvement.
That's a truly powerful point, highlighting that major disconnect between what we know works and what's actually happening in practice. Even with these incredible medical advancements, and even if we achieved perfect GDMT implementation, a persistent and profound question remains. What about the risk that GDMT doesn't fully mitigate? This brings us squarely to the unanswered question of residual risk. How do we grapple with the fact that even on optimal therapy, some risk still exists?
That's the core of the ongoing debate, and a huge challenge for clinicians and patients. Despite the superior outcomes with optimal GDMT, Despite LVEF improvements and reduced cardiovascular death, the reality is there remain unmitigated risks of SCD. GDMT is phenomenal, but it doesn't eliminate all risk. These residual risks, even in patients on advanced GDMT, were reported to be as high as 9.2% for cardiovascular death in DAPA-HF and 10% in EMPEROR-reduced. Now, those are cardiovascular deaths, not just SCD, but they highlight persistent risk. Interestingly, a post-hoc analysis of patients with improved LVEF in the DELIVER trial found over half the deaths were from non-CV causes, like cancer or lung disease. However, importantly, for SCD specifically in that group, there was a significant reduction with dapagliflozin compared to placebo. So the SGLT2I did mitigate some specific SCD risk, but overall risk from various causes remains. A zero-risk scenario is rare. This persistence of residual risk leads to a fundamental, hotly debated question. How much residual risk still warrants protection with an ICD? Where do we draw that line?
Is there any kind of benchmark?
Well, for perspective, in hypertrophic cardiomyopathy, an ICD is typically recommended if the annual SCD risk is estimated 1.2%. That particular threshold is already 10 to 20 times higher than the general population's risk, but for the broader HFrEF population on modern therapy, there's currently no broad consensus on what absolute level of residual risk is truly acceptable or definitively warrants the lifelong commitment to an ICD. It's a very active area of discussion and research. And we also have to factor in the cost-benefit equation from the patient side, particularly the non-trivial rates of ICD complications. These aren't minor issues.
Like infections. Exactly. Infection risk is maybe up to 1.7% within 6 months, rising to 4.3% within 2.5 years. These can be severe, needing hospitalization, even device removal, a major procedure. There are also risks of lead fractures, those inappropriate shocks we mentioned, psychological distress. These are not insignificant risks. They absolutely must be weighed against the potential benefit. So before recommending an ICD, providers have to carefully evaluate all these competing risks: SCD risk, risk of dying from other causes, and the risks of the device itself. They need to incorporate thorough clinical assessments, maybe additional testing, when counseling patients on their overall individualized risk and what an ICD can realistically offer them.
That truly highlights the ethical and clinical tightrope providers walk daily. If current criteria aren't perfect, and we have this persistent question of residual risk, what's next? What research is happening right now to make these life-saving decisions even more precise, moving beyond just LVEF into a truly individualized approach? What does the horizon look like for ongoing and future ICD research?
It's an incredibly exciting time in cardiology research, precisely because we recognize these limitations. There's an urgent push for greater precision in patient selection. We know, without a doubt, that ICD implantation doesn't give a survival benefit to all patients who might technically qualify based only on LVEF A35%. In fact, some ICD recipients live for years without ever having a life-threatening arrhythmia or needing any therapy from their device. This situation represents a huge opportunity to avoid unnecessary implants, which carry risks and costs. So there's an urgent need for new studies to rigorously define the specific patient phenotype, that unique mix of clinical traits, imaging findings, maybe genetic markers who will most definitively benefit. This is crucial not just for outcomes, but also for better shared decision-making, so patients understand their true likelihood of benefit. To move beyond LVEF as the sole, blunt tool, researchers are actively exploring more personalized approaches. One fascinating ongoing study is Tracer ICD. It's enrolling a large group of new primary prevention ICD patients.
The goal is to meticulously track their clinical and functional paths over time, gathering tons of data on their health, device performance, quality of life. This rich data set will then be used to refine personalized outcomes prediction models.
Trying to build better prediction tools, basically.
Exactly. Moving closer to understanding who truly benefits and how they fare long term. The role of cardiac magnetic resonance, or CMR, imaging is also a rapidly growing area. CMR is powerful. It visualizes the heart muscle in incredible detail, picking up subtle things like myocardial fibrosis or scarring that other imaging might miss.
And scarring is linked to arrhythmias?
Strongly linked, yes.
Yeah.
So there are several important ongoing trials specifically looking at ICDs in non-ischemic cardiomyopathy patients where CMR has confirmed fibrosis, testing if this is a better risk marker. These include the British trial, comparing ICD CRTD versus an implantable loop recorder CRTP for all-cause mortality, helping sort out the defibrillator's specific value. The CMR ICD trial, evaluating if ICDs decrease death in NICM patients with LV dysfunction and fibrosis. The CMR Guide DCM trial, also evaluating ICDs in NICMR with LV dysfunction based on CMR.
Yeah.
And the Spanish 1 trial, which is really interesting, is testing if a personalized strategy using genetics and CMR is non-inferior to standard ICD criteria.
So really trying to integrate advanced imaging and genetics into the decision.
Precisely. These trials are rigorously testing if this leads to better, more targeted patient selection than LVEF alone. We also have crucial post-MI stratification trials continuing that work. Protect ICD is applying personalized risk stratification in post-MI patients with LVEF 40%, looking for more granular predictors. And it's really important to mention PROFIT. This trial directly addresses the central tension we started with today. It aims to determine if optimal contemporary medical therapy alone is non-inferior, basically, not worse than therapy, plus an ICD for reducing all-cause mortality in post-MI patients with symptomatic HF and LVEF of 35%.
So Profit is asking, with today's best meds, do some post-MI patients still need the ICD for survival?
Exactly that. Can the new potent GDMT in some cases render the ICD unnecessary for overall survival benefit? The results of PROFID and these other trials will profoundly influence future guidelines.
Okay, that gives us an incredible glimpse into the future of precision medicine. But for a clinician in the exam room today, with a patient right there, what are the actionable takeaways? How do they navigate these complex decisions right now, using the best available evidence while we wait for these new trial results? What practical guidance can clinicians use now when considering an ICD?
That's the vital, immediate question, isn't it? While we await those results, several key things refine current decision-making. First, the etiology of cardiomyopathy, the specific cause of the heart failure, plays a significant role. For example, patients with arrhythmogenic cardiomyopathy is often genetic, like ARVC, or specific variants affecting proteins like LMNA or desmosomal proteins, are inherently at increased SCD risk due to the disease itself. In these specific groups, ICD indications often differ. The decision might hinge on the exact genetic variant, phenotype, family history. Generally, the threshold for an ICD is lower because these diseases are often progressive with a high incidence of ventricular arrhythmias, sometimes independent of LVEF.
So the why matters a lot.
Absolutely. Another crucial factor which CMR is helping us see is the significance of scar burden and potential for remodeling reversal. That late gadolinium enhancement, LGE, on CMR indicates scarring. Scarring is strongly linked to arrhythmias and SCD. Midwall scar specifically is an independent predictor. For patients found to have significant scarring, maybe more than 15% of their heart muscle, ICD therapy is highly advisable due to that high SCD risk. Also, patients with extremely low LVEF and a severely dilated heart from irreversible causes, like multiple MIs causing extensive damage, have a low chance of their LVEF improving much, 35%. They might warrant earlier ICD consideration because structural recovery is unlikely. Conversely, LVEF improvement with GDMT is vital and often hopeful. LVEF is the main referral criterion, inversely related to SCD risk, lower LVEF, higher risk. But significant improvement with optimal meds can change that risk profile dramatically.
How much improvement makes a difference?
Well, studies have noted that every 1% increase in LVEF is associated with a remarkable 22% decrease in SCD. Another study linked a 5% LVEF increase to a 14% risk reduction in SCD, cardiac arrest, and serious arrhythmias.
So even small bumps help.
They really do. This gives practical guidance. If LVEF improves after 3 months of good GDMT, but isn't yet over 35%, then watchful waiting, continuing to optimize GDMT, and reassessing LVEF in another 6 months can be a very reasonable approach. It gives the meds time to work fully and might avoid an unnecessary implant. Finally, the promise of precision medicine, including artificial intelligence AI, is truly on the horizon. It's still uncertain if incorporating all these factors, competing risks, CMR genetics, will definitively enhance personalized ICD use beyond current guidelines. But AI could be transformative for predicting personalized SCD risk.
How would AI do that?
Imagine AI sifting through thousands of data points per patient. Genetics, imaging, lifestyle, medical history, how conditions interact. One promising, though not yet fully published, AI study analyzed data from thousands of SCD patients and controls. It identified intricate patterns in individuals with over 90% SCD risk. These high-risk individuals actually represented over a quarter of all SCD cases studied.
Wow, pinpointing the highest risk group like that.
Potentially, yes. Moving from broad strokes to personal risk assessment, it's incredibly promising for targeted prevention. But caution is key. We need full publication and confirmatory studies before this is ready for prime time. The future's exciting, but rigorous validation is paramount. So to kind of summarize our deep dive today, the risk of sudden cardiac death and also progressive heart failure death can be considerably reduced through optimal implementation and dosing of contemporary GDMT. That's huge. While primary prevention ICD therapy has undeniably been shown to reduce all-cause mortality based on that older trial data, There are clearly opportunities and really a pressing need to better target this therapy. We need to retest its precise benefit in patients who are now getting these potent modern medications. As new data emerges from these cutting-edge trials, guidelines will almost certainly be updated. Primary prevention recommendations for ICDs could become much more personalized, based on etiology and individual risk profiles.
Crucially, though, this desire for more personalization should not, under any circumstances, eliminate the fundamental necessity to ensure that all patients who are truly at risk for SCD continue to be offered life-saving therapies, including the ICD, if that remains the best path for them after careful consideration.
This deep dive really shows us that medicine is never static, is it? It's a continuous, dynamic pursuit of precision, always balancing broad guidelines with the individual needs and complexities of each patient. As incredible new technologies like AI enter the fold, promising even more tailored interventions, how do we, as informed individuals, navigate a world where life-saving decisions become ever more specific to us, but the basic access to this groundbreaking personalized care still remains a significant, sometimes heartbreaking challenge for so many? Something to think about. Okay, to wrap up our deep dive, here are the key insights to take with you.
Right. First, ICD guidelines are evolving. Those current recommendations for primary prevention of SCD and heart failure, they're being reevaluated because they were based on trials done before our modern, highly effective guideline-directed medical therapies, GDMTs, were standard. Second, GDMT is a game changer. Contemporary GDMT, those four pillars, beta blockers, RAS inhibitors like RNI, MRAs, SGLT2I, significantly reduces both illness and death in heart failure, including SCD risk. Optimizing these meds can profoundly improve outcomes and sometimes even improve heart function enough to potentially delay or avoid an ICD. Third, the real-world challenge. Despite these advances, real-world SCD rates haven't dropped as hoped. Partly due to that significant implementation gap, suboptimal use of GDMT outside trials, real-world patients often have more comorbidities, maybe can't tolerate optimal doses, contributing to continued high risk. Fourth, beyond LVEF, a holistic view. Assessing risk and ICD benefit needs more than just the left ventricular ejection fraction.
Factors like age, other health problems, frailty, kidney disease, diabetes, AFib, the specific cause of the heart failure, even scar tissue seen on imaging, all must be considered for a truly personalized assessment. Fifth, shared decision-making is key. Open, patient-centered talks are crucial. Doctors need to understand patient values and goals, covering not just potential survival benefits, but also complications and the impact of other conditions, and these talks might need to happen again as things change. Sixth, addressing disparities. Those landmark ICD trials historically underrepresented women and non-white individuals. This might lead to disparities in who gets ICDs and could skew outcome data. We need more inclusive research and focus on structural barriers to ensure equitable access. Seventh, future of precision. Ongoing trials are exploring more personalized approaches, using tools like cardiac magnetic resonance, CMR, imaging to see scarring, and even artificial intelligence AI to predict individual SCD risk, moving beyond one-size-fits-all. And finally, eighth, balancing act. While personalization is the future, and GDMT is powerful, ensuring that all patients truly at risk for SCD are still offered, life-saving ICD therapies remains essential, even as guidelines evolve to reflect the newest evidence and more precise risk assessment.
Perfect summary. Now, let's test your knowledge. Here are 10 questions to solidify what you've learned from this deep dive. Question 1. Which of the following is highlighted as a leading cause of death worldwide, outnumbering cancer mortality? A. Stroke. B. Myocardial infarction. C. Sudden cardiac death, SCD, diabetes complications.
The answer is C, sudden cardiac death, SCD. We mentioned early on it's a leading cause of death globally, surpassing cancer mortality rates.
Question 2. The landmark clinical trials that led to current ICD guideline recommendations for primary prevention in HFrEF patients largely preceded the development of which of the following? A. Coronary artery bypass graft surgery. B. Early forms of medical therapy like aspirin. The four pillars of contemporary guideline-directed medical therapies, GDMTs, cardiac catheterization procedures.
That would be C. The four pillars of contemporary GDMTs. A central theme was that those pivotal ICD trials happened before modern quadruple therapy was established.
Question 3. In the Danish trial concerning ICD efficacy in patients with non-ischemic systolic heart failure, what was a significant finding related to overall mortality and SCDA? A statistically significant reduction in overall mortality with ICD-B. No statistically significant reduction in overall mortality, but a significant reduction in SCD with ICD-C. A significant increase in overall mortality, but no change in SCD with ICD-D. No change in either overall mortality or SCD with ICD.
The answer is B.
Danish showed no statistically significant reduction in overall mortality, but it did show a significant reduction in sudden cardiac death with the ICD.
Question 4. According to the deep dive, what is a key reason why real-world SCD rates may not have declined as rapidly as hoped, despite advances in therapies? A. Increased patient adherence to medical therapy. B. Poor implementation of guideline-directed medical therapy, GDMT, declining prevalence of heart failure globally. D. Over-reliance on ICDs rather than medical treatments.
That's B. Poor implementation of guideline-directed medical therapy, GDMT. We discuss how this implementation gap contributes to continued high real-world SCD rates.
Question 5. For which of the following patient populations does the U.S. guidelines designate a Class 3 no-benefit recommendation for ICD implantation? A. Patients with NYHA functional class I symptoms and ischemic cardiomyopathy. B. Patients with LVEF a 35% on optimal GDMT. Patients with advanced HF, NYHA functional class 3, and limited life expectancy. D. Asymptomatic patients at least 40 days after MI with LVEF a 30%.
The answer is C. Patients with advanced HF, NYHA functional class 3, and limited life expectancy. Guidelines explicitly state a class 3, no benefit potential harm for this group due to competing risks and limited potential benefit.
Question 6. Which of these comorbidities is associated with an increased risk of inappropriate ICD shocks and potential post-traumatic stress disorder in patients? At C, atrial fibrillation, AFib. We talk about how concomitant AFib increases the risk of inappropriate shocks, which can be very distressing. Question 7. What did the PROVE-HF study demonstrate regarding AIR and I therapy in ICD-eligible patients? A. It increased the rate of ventricular arrhythmias. B. It improved LVEF to 35% in a significant percentage of patients within 6-12 months. C. It led to more frequent ICD therapies. D. It had no impact on LVEF or arrhythmia burden.
The answer is B. PROVE-HF analysis showed ARNI therapy improved LVEF to 35% and 32% at 6 months and 62% at 12 months among those initially eligible for an ICD based on LVEF.
Question 8. Despite superior outcomes with GDMT, what significant concern does the deep dive highlight regarding residual risk? A. The complete elimination of SCD risk. B. A consensus on what absolute level of residual risk is acceptable. C. The persistence of unmitigated SCD risks. The GDMT makes ICDs completely unnecessary.
C. The persistence of unmitigated SCD risks. We emphasize that even with optimal GDMT, some risk of sudden cardiac death remains.
Question 9. Which diagnostic tool is being increasingly explored in ongoing ICD trials to identify myocardial fibrosis and better predict SCD risk in non-ischemic cardiomyopathy? A. Electrocardiogram ECG.B. Echocardiography.C. Cardiac magnetic resonance, CMR-D, chest X-ray.
That would be C. Cardiac magnetic resonance, CMR. We discussed several ongoing trials using CMR to identify myocardial fibrosis, LGE, as a potential risk marker.
And question 10. According to the deep dive, what effect did an increase of 1% in LVEF have on SCD risk in one study mentioned? A. 1% increase in SCD risk. B. A 10% decrease in SCD risk. C. A 22% decrease in SCD risk. D. No significant change in SCD risk.
The answer is C. A 22% decrease in SCD risk. We noted that the study finding that every 1% increase in LVEF is associated with a 22% decrease in SCD shows how sensitive risk can be to LVEF changes.